Okay, I think nowadays there is quite a controversy about not how to treat. I don't think there is a controversy about how to treat high-risk smoldering. It's mainly the controversy about what are the most accurate parameters in order to identify the high-risk populations. Until now, there had been two classifications, was the Mayo classification and the Spanish PETEMA classification. Now we have agreed that the 2020 classification probably is the best one to have more than 2 grams per deciliter of paraprotein, to have more than 20% plasma cell in the bone marrow, and a free light chain ratio of more than 20. And if you have 2 or 3 of these criteria, you have already 50% risk of progression at 2 years. But on top of this, we can calculate the exact score based on this classification, because it's not the same to have 20% plasma cell or to have 40%, or a free light chain ratio of 20, or a free light ratio of 50. As you can imagine, the risk is different. And we have established the score, and patients having a score above 9 or 12 have by sure more than 50% risk of progression. On top of this, you should evaluate the evolving pattern, also the cytogenetics. Also, you should look for pure genomic, also for MRI in case there is already one focal lesion. And if you put all this together, plus the circulating tumor cell that we can discuss later on, if you put all this together, you can calculate for the patients more accurately what is the risk of progression, 50% or 80% in 2 years. And according to this information, you can share with the patient, and the patient should make the final decision together with the doctor. Regarding treatment, as you had mentioned, data has been approved, but probably this is not going to be used as the standard of treatment, because how are we going to treat the high-risk smoldering patients? I think they are going to be treated according to age, exactly the same as active myeloma patients. In other words, if you have in front of you a patient that has really high risk of evolution into active myeloma and is not a transplant candidate, probably you will move for a quadruplet instead of a single agent. We use lenalidomide in the past, now data that has been approved, but probably the next step is to use the quadruplet, or alternatively, to use a bispecific antibody or a CAR-T. We have already preliminary data from the Boston group and from our group that the use of bispecific antibodies as well as CAR-Ts are extremely valuable in the high-risk myeloma patients. Regarding the transplant patients, we will go in the same direction. In fact, the GEM-CESAR trial that we conducted in 90 patients has shown beautiful results with high rates of minimal residual disease. However, we realized that still patients has biochemical relapses frequently. And we decided, and this was presented at the recent ASH meeting, in order just to try to avoid moving from biochemical into a clinical relapse, to introduce the concept of early rescue intervention. And this concept of early rescue intervention was based on the use of daratumumab, pomalidomide, and dexamethasone. We have treated in total 43 patients, from the 43 patients with biochemical relapse, we treated with dara-PD 29 patients. The other 14 patients prefer not to be treated at this moment. And I can tell you that the vast majority of the patients responded to treatment. Overall response was 90%. The complete response was 50%. And the time to progression at 50 months was 95%. Nevertheless, I can also mention that there were also some biochemical progressions also under data PD, the time to biochemical progression at 50 months, the proportion was 74%. Therefore, what is my message? My message is that the concept of early rescue intervention, in order to avoid the possibility of having CRAB symptoms, is well established and is very attractive. But for me, what is most attractive is to use the treatment that could eradicate the disease by the decision of intervening in the high-risk smoldering myeloma patient at the time of diagnosis.